in succession to the videos what I have been taking up these days on the pediatric patients, the pediatric age group, in succession to those videos, now today's videos, from now onwards, I'll be taking up the syndromes. So different types of syndromes are there, and I'll be basically focusing upon the syndromes what are associated with the pediatric age group, the syndromes what are most commonly seen in children. So from now onwards, slowly and gradually in succession, I'll be taking up different syndromes what are most frequently seen in the young children. So starting with, and in this video, today's video, I'll be focusing upon the Down syndrome, and particularly in this video, we'll be focusing upon the clinical features as to what are the clinical features what are most commonly seen in a child with Down syndrome. So starting with the first line, what I need to say, the name Down syndrome, how this syndrome has been given the name Downs. So it was John Langdon Down in 1866. He defined it as a condition that he defined this Down syndrome as a condition, and he named it as in the form of Mongolian idiocity. Now, before getting into the detailed discussion, let me just define what do you mean by a term syndrome. So syndrome, it is a condition, it is a combination, it is a group of signs and symptoms which together manifest in an individual. So a particular sign, a particular symptom cannot make a syndrome. When we talk of syndrome, it is particularly a combination of a huge variety. There will be myriads of signs and symptoms which are associated together to be called it as a syndrome. Since this is Down syndrome, and this is particularly a chromosomal aberration, a chromosomal abnormality, what is seen mostly due to the trisomy of chromosome number 21. So as you all might be very well aware that trisomy is occurring. Trisomy simply means that the 21 pair of chromosome in humans, there are 23 pairs of chromosomes. 22 pairs, they are autosomes, and one pair, it is the sex chromosome. So this, out of the autosome, that is the 21st chromosome, it is going to have an extra copy of the 21st chromosome. So usually the 21st pair, that is the 21st pair of the chromosome, it is usually going to consist only 2 chromosomes. But in case of trisomy 21, there will be presence of an extra chromosome in with respect to the normal presenting the 2 chromosomes. So the 2 chromosomes what are there, in addition to it, there will be presence of an extra chromosome from on the number 21. So that was Langdon Down who defined it as the Mongolian idiocity, and this syndrome is the best known and the most common of all the malformation syndromes which occur in it is most commonly known, it is most frequently seen, and it is the most common syndrome what are frequently seen in children. So, and what causes this syndrome? So there has been various research studies what have been conducted, and it has been found that it is increase in the mother's age. So nowadays, in the present modern day era, when the maternal age of conceiving a baby, conceiving a child is increasing, so it is the chances of having a child with Down syndrome increases when the mother is having an increased age. So the Down syndrome children can be born to any mother. It is written that occurs in mothers of all ages. It is not very particular that elderly age group mothers are going to have children with Down syndrome, but the chances, the risk factors increases with the increase in the maternal age. So it occurs in mothers of all ages. It can occur in any mother, but the chances, the prevalence of having a child with Down syndrome increases with increasing maternal age. Now, moving on to the clinical features. Now, when looking at the clinical features, what do we find is that the newborn, the child which is born is going to have the fetal brain growth is delayed. So the brain of the child is going to be, the development of the brain is going to be delayed, and the as a result, the child will be having a microcephalic head. That is, the small head will be present, and the most important, the interesting feature of this Down syndrome, that these children, these newborns who are there, they are mostly referred to as the good babies. And why they are called as good babies? Just because they are not easily disturbed. They do not cause much botheration to the mother. They are least distracted to the external stimuli, and they do not disturb their mothers. So, just because of this, that their mothers face very little trouble, they give very little trouble to their mothers, and they are not easily disturbed. Even the external stimuli, a normal baby is going to respond very appropriately to the external stimuli, but the children who are affected with Down syndrome, they are not easily disturbed even by the presence of an external stimuli. So that's why they have been referred to as good babies, because they cause very less trouble to their mothers. Now, moving on to why this they are why such a decreased environmental response is there, why there is a decreased response to the environmental stimuli. Now, such a trait, it is possibly going to reflect that there is a decreased response to the external stimuli, and the muscles what are there, they are going to show marked hypotonia. So whatever the normal tonicity of the muscle is there, in such children, the muscle tone, it is somewhat marked hypotonia is there. So these children, they do not respond to the external stimuli in the most likely fashion as they should respond. Now, moving on to the next, what is the hallmark? Now, mostly what is seen is that the children with Down syndrome, they are going to have an IQ level of between the range of 30 to 50, and that is the cause that such children, they are mentally retarded. So these children they are mentally retarded, and this is the hallmark of a Down syndrome child. Now, moving on to the next feature, that these children, Down syndrome patients, they are very, very cooperative. They are over friendly. These children, they are very friendly. They are very mixing up with the people, and they are in other words, what we can say is that these children, very few patients are found to be aggressive or hostile, because there are certain children who are very aggressive and hostile, but this is not so in case of Down syndrome patients. These patients are very friendly, they are very happy. These people, they tolerate to the friends, the people, in a very happy and a welcoming mood. So these very few patients, they are judged to be aggressive or hostile, and they are least likely to show certain kind of maladaptive behavior. So their behavior, it is not that they are not going to adapt to the place where they are visiting or where the people whom they are talking. So they tend to display that they have a very least, there is a likelihood to display any kind of a maladaptive behavior. Now, moving on to the growth and the skeletal abnormalities. Now, when talking of the skeletal and the growth abnormalities, what do we found is that there is even in the intrauterine life or after birth, either it is the prenatal period or the postnatal growth deficiency is found. In the uterine, in the mother's womb, they are going to show a retarded growth, and as well as even after birth, they show diminished or retarded growth. And also there is a tendency of such mothers who are conceiving these Down syndrome babies, there is a likelihood that they could have premature births. So these children, they are mostly prematurely born if they are having an extra copy of the chromosome 21. So there is a chance of a premature birth, as well as this osseous maturation. The bones what are going to mature, the appropriate time a particular bone needs to mature. What is seen in children of Down syndrome, that their osseous, the bony maturation of the different body parts is significantly delayed. Now, moving on to the craniofacial features. Now, I'll be focusing upon what are the special typical craniofacial involving the cranium of the brain as well as the facial skeleton. So what are the craniofacial features what are mostly seen? Now, such children, they are going to have brachycephaly. Means brachycephaly, they are going to have a short and a broad skull. What kind of a skull? Short and a broad skull. And mostly what is seen is that the skull, the breadth of the skull is mostly 80% of the length of the skull. Just imagine if the skull is having a 100 length, so the breadth of the skull is going to be 80 parts of it. Just imagine. So they have a broad and a short and a broad skull. The breadth of the skull is mostly 80% of the length of the skull, and they are going to have a flat occiput. So when I talk of occiput, this is the occipital bone. So this occiput, in most of the children, most of the normal children, what do we find? It is a somewhat rounded in shape. But in children of Down syndrome, they are going to have a flattened occiput. This occipital bone is somewhat flattened. So this is the flat occiput, what is seen in a Down syndrome patient. Now moving on to the fontanelles. So as you all might be very well aware, there are different fontanelles what are present in the different parts of the skull. At this fusion of the different sutures, the parietal sutures, the sagittal sutures, the lambdoid sutures, whatsoever sutures they are present in the skull, there is presence of an opening which are known as fontanelles. And these fontanelles, they close after a certain period of time. When a baby is born, since the brain growth is there, so in order to adjust the growing brain, these fontanelles are present. And as the skull is going to mature, as the brain is going to grow, slowly and gradually the openings, these fontanelles what are present in a baby's skull, what is going to happen is they are going to close. But in cases of Down syndrome patients, what do we find is that there are large fontanelles which exhibit delayed closure. As compared to a normal developing child, the child having Down syndrome will be having a delayed closure of the fontanelles of the skull. All right, and particularly the frontal and the sphenoidal sinuses in the skull, there are different sinuses. The frontal and the sphenoidal sinuses, they are absent, as well as the maxillary sinus. So then the maxillary sinus, what is seen, it is hypoplastic in case of a Down syndrome patient. So this maxillary sinus, it is underdeveloped, it is hypoplastic. Now moving on to the next clinical feature, that there is a bony mid-face hypoplasia. So the mid-facial region, since the bones are hypoplastic, they are unable to mature, so that causes a diminished mid-facial deformity is going to occur, and will be bony mid-face hypoplasia leading to, now since this part of the face is going to be hypoplastic, it is going to show diminished growth, so that is going to lead to ocular hypertelorism. So hypertelorism is a technical term used to indicate when two organs, they are separated very distantly. All right, so in cases of this kind of a Down syndrome patient, these eyes, ocular hypertelorism, so these two eyes, they appear that they are situated a bit distant from each other. As compared to a normal individual, these ocular hypertelorism, that these two eyes, they are somewhat located distant away from each other. So this ocular hypertelorism is there, and mostly in patients of Down syndrome, the small nose is present with a flat nasal bridge. So the nasal bridge is somewhat flattened, a flattened nasal bridge is there, and there is relative mandibular prognathism. So there is the chances of having a class 3 malocclusion in such patients, and this mandibular growth is somewhat excess mandibular growth is there, and that is going to lead to a mandibular prognathism. Prognathism means something is going ahead. So as compared to the maxilla, since there is a mid-face deformity, mid-face deficit is there, so the mandible is going to grow to a greater extent, and that is going to lead to a mandibular prognathism, means the mandible is going to project somewhat forwards. So there is a relative mandibular prognathism, and there is upward slanting of the palpebral fissures. Now see, these are the sides, the edges of the eyes, these are the palpebral fissures. And now in the patients of Down syndrome, the palpebral fissures, there are upward slanting of the palpebral fissures, means the palpebral fissures, when we draw a line from the inner canthus, we will find that there is an upward slant of the palpebral fissures. The epicanthic folds, now the medial and the inner canthus of the eye, these epicanthic folds, they are going to cover the inner canthus of the eye, and there is nystagmus. So the presence of nystagmus and cataract is there. Now moving on, the ears, when we talk of ears, so these ears, in patients of Down syndrome, there are low set ears which are somewhat folded. Low set ears are there, and the ears, they are somewhat low set ears are there, and they are a little bit folded as well. Now when we talk of the lips in the orofacial region, when we talk of lips, so nystagmus I forgot to discuss. So nystagmus is then when there is a rapid involuntary movement of the eyes. So the technical term describing nystagmus is these, when eyes are, when we look, when we stare, what do we have? We have normal children, they are going to have normal voluntary movements. But nystagmus is a condition where involuntary rapid movement of the eyeballs are going to occur. So moving on to the description of the lips. So in such patients, the lips are somewhat broad and they are irregular with fissures and cracks. So there can be presence of fissures and cracks in this, and the lips are dry as well as macroglossia. The children are going to have an enlarged tongue. With these enlarged tongue, there can be fissures and even cracks present on the tongue. And when we talk of the mouth, so somewhat, since there is an enlarged tongue, okay, when there is a enlarged mouth is there, so sometimes what is going to happen is that just because of the enlarged tongue, these children, they have a protruding tongue that causes the protrusion of the tongue. And when we talk of the palate is narrow and shallow. And since the palate is very narrow and it is little bit shallow, so that is going to give it is a very high arched palate is present. So high arched palate is there. And when we talk of the articulation defects, see, normal children, when they are going to talk, what happens is they are able to frame set particular words in a sequential order, and then they are going to frame a sentence. But when we talk of articulation defects, they are unable to properly form a frame or sentence. So there is articulation defects. The pronunciation is often slurred. The slurring of the speech is there. Slurred speech, slurring is oftenly seen, and most making the speech incomprehensible, means it is difficult to understand what these children are actually trying to say, what these children are actually willing to say. Now moving on to the voice, what kind of a voice these children have? So voice is mostly hoarse, it is raucous, good evening, hoarse, raucous, and low pitched voice is there. So the pitch of the voice is little bit, the pitch of the voice is low. And what do we find is these children, they are predisposed to increase in the periodontal disease conditions. So periodontal disease conditions in most of 90% of the children, they're going to have periodontal disease problems. And what most commonly is seen is it is the exfoliation of the lower central incisors. The lower central incisors, they are exfoliated just because of the periodontal disease. They are exfoliated early in their life. Now moving on to how do the sequence and the pattern of the permanent or the deciduous teeth is going to occur. So there is eruption of both deciduous and permanent teeth. It is delayed. Will be a delay in eruption. Either it is the primary milk teeth or it is the permanent teeth. Their eruption is delayed, and irregular sequence of eruption is seen. Now there are the teeth what are going to erupt into the oral cavity. They are having a particular timing, their particular aged time where a particular tooth needs to erupt into the oral cavity. Now since in the cases of Down syndrome patient, what do we find is that the sequence of eruption is haphazard. It does not follow the usual trend, as well as what do we find is that the third molars, the second premolar, and the lateral incisors, they are most frequently absent in a child suffering from Down syndrome. Whereas moving from the another dental finding, it is the malalignment of the teeth. The teeth are malaligned, and what do we find is that in patients of Down syndrome, there is presence of a posterior crossbite, and this posterior crossbite, that it is also accompanied by a mandibular overjet is there, the mandibular prognathism is there, that can lead, there can also be presence of an anterior open bite, and as well as there can occur crowding of the teeth, and in certain cases it has also been found that the teeth are spaced. Okay, sure. Now, moving on to the other findings. So, other findings, what do we find is that the general findings in the orofacial up till the neck region, these children are going to have a broad and a short neck. So, the length of the neck, what is normally seen, they are going to have a very small neck with the face being more bulkier and small neck is there is chances of umbilical hernia. So hernia can be of many types, but in some patients of Down syndrome, this umbilical hernia is seen. When talking of the genitals, the patients, these children are going to have hypogenitalia, there is deficiency of the growth of the genitals, as well as the condition of cryptorchidism, that is the undescended testicles. Mostly the testes are stored in the into the abdomen in the intrauterine life. Just before birth, the testes descend into the scrotum via the inguinal canal. So what do we find in a patients of Down syndrome? That there is presence of cryptorchidism. That means the testes are unable to descend into the scrotum sac. So this is another finding which can be seen in a patient of Down syndrome. And what do we find is there can be presence of short and broad hands with brachydactyly. So brachydactyly means the length of the bones of the fingers. They are going to be small fingers due to the small bones of the fingers. So just because of the digits, the bones of the digits, they are going to be, the growth is deficient, the growth is diminished. So what do we find is that in brachydactyly, the digits, the fingers, they are somewhat shortened. These are going to have, the children are going to have a small fingers, as well as in a normal human individual, in a child, what do we find is there are presence of so many creases. So this creases in case of a Down syndrome patient, what do we find? There is presence of a single crease on the palmar surface. What do we find? There is going to be presence of just a single crease in a patient of Down syndrome. And also the very important feature that in certain children, what do we find is there is presence of a clinodactyly. So this clinodactyly is mostly seen in the little finger, where the little finger is somewhat bent or somewhat crooked. It's somewhat tilted. So in patients of Down syndrome, in such children, what do we find is that the presence of clinodactyly, particularly the rest of the fingers will be normal, but it is only the little finger which is somewhat curved or little bit bent. And it is an unusual finding to be found in both the hands. It can be present in either of the hands of the child who is suffering from Down syndrome. So this clinodactyly means the little finger, most commonly the digit what is involved, it is the little finger. And in clinodactyly, the digits are, okay, sure, I forgot this. Please make me remember in the comment section. So in clinodactyly, the little finger is little bit curved and it is somewhat bent. So this clinodactyly is mostly seen in the little finger, and it is a very rare finding that it is present in both the hands. It can be present in either of the hands. Now, moving on to the next feature, that there is hyperflexibility of the joints. So in such children, the bones, the joints, they are hyper flexible. They can be twisted and turned in any of the fashion. So there is flexibility of the joints. And when we talk of the immune system, see, the children who are suffering from Down syndrome, the immunodeficiency can manifest in Down syndrome. It can manifest in the form of that these children are going to there is an increased susceptibility to infections. So these children, they are more susceptible to infections and they can catch infections very frequently. So there is a decreased immunocompetence. Now, when talking of the risk, particularly in some of the cases it has been found that there is an increased chances of developing a neoplasm. So neoplasm, it is the malignant transformation of the cells, an abnormal and or abrupt growth. So neoplasia, there is an increased chances of neoplasia in a child who is suffering from Down syndrome. And particularly the most commonly seen neoplasia, what is seen in Down syndrome, it is the leukemias. So Down syndrome patients, they are mostly in some of the, if they are going to have malignant neoplasm formation, neoplasm development is there, mostly it is seen that there is a chance, there is a probability that these children might suffer from nuclemia if it is the neoplasmic, the neoplasm is going to occur, if there is a neoplastic transformation occurring. Now moving on to the next feature, that is there is an increased frequency of okay, there is an increased frequency of autoantibodies, and these children, they are going to age earlier. Means their aging, their growth will be stunted, they are mentally retarded, as well as when we talk of these children, this very early they start aging up. As compared to the normal aging process, these children are going to age earlier. So students, this was a very short discussion about the clinical features, the skeletal and the craniofacial features, what we find in Down syndrome patients. If you do have any queries, see, I cannot take up questions right in the live session. You're most welcome to comment me in the comment section. And students who are visiting my channel for the first time and they haven't subscribed yet, go do subscribe the channel, and don't forget to press the bell icon so that you can be further updated for my upcoming videos. If you do have any queries or comments, please do comment me in the comment section. Thank you for watching. I'll be focusing this video for a short while. Those who ever wants to have a little bit of quick notes, and this screenshot of this whiteboard notes I'll be posting on my Facebook page. You're most welcome to have a look either in the playlist section in the YouTube as well as on my Facebook page on NEET PG entrance. So thank you for watching.